Good day. My name is Paul Wax. I'm the Executive Director of the American College of Medical Toxicology, and I'd like to welcome you to our weekly webinar series on the medical and public health considerations of COVID-19. The headline on CNN currently, as of this hour, is that the U.S. reaches 3 million virus cases at a ferocious pace. The first million cases took 99 days, the second million 43 days, and the third million just 28 days. We are very fortunate to have two outstanding presentations today that will address very important issues regarding COVID-19. The main presentation will be on developing a vaccine and vaccine strategy for COVID-19, and this will be followed by some updates from the front lines from Arizona and New Mexico. Next slide. I'd like to thank our webinar series partners. Next slide. All these webinars are recorded and will be posted on to the ACMT website within 48 hours. You'll get a notification of when the recording is posted. The website is acmt.net/COVID-19 web. And any questions specific about this webinar series can be addressed to us at info@acmt.net. Next slide. These webinars feature a very important, hopefully useful Q&A session toward the end. Please type in your questions into the Q&A box or the chat function during the webinar, and we will get to as many of these questions as we can. You can also, for those watching on either YouTube or Facebook Live, you can type in questions into the chat functions on those devices as well. Next slide. I'd like to thank my co-moderator for the series, Ziad Kazi, who will be participating as a moderator for the Q&A. Next slide. And I'd also like to welcome our guest moderator, Julie Weber. She's the president-elect of the American Association of Poison Control Centers, and we're very fortunate to have her here today, and she'll provide some of the introductions later on, as well as serve as a moderator of the Q&A. Next slide. Well, I'm delighted to introduce our plenary speaker, Dr. Evan Anderson. Dr. Anderson is an associate professor of pediatrics and medicine at the Emory University School of Medicine in Atlanta, Georgia, and he's very much engaged with the developing of the COVID vaccine. We feel this is of utmost importance to all of us in terms of understanding the vaccine development process, the strategy, and the timeline. And at this point, I'd like to turn it over to Dr. Anderson for his presentation. Thank you.
Thank you to the organizers for the opportunity to talk with you about this topic. And if we could go on to the next slide. So here are listed my conflicts and disclosures. Probably the most relevant is that I do serve as the Emory PI for the mRNA 1273 study, which is the Moderna vaccine. We can go on to the next slide. So this is a figure that that highlights some of the emerging and re-emerging infections that have been identified over the past 20 or so years. And what you can see is that actually there have been a large number of emerging and re-emerging infections identified in the recent past. And this list, of course, is missing a very big one, which is on the next slide, which was the red dot that initially appeared, if we can go on to the next slide, appeared in China and obviously now is throughout the entire world. So moving on to the next slide. I'll give you a little bit of background here that's fairly relevant, that is, I think, crucial as we start to think about a vaccine for SARS-CoV-2. So this was initial data that was published from China, and what you can see here and is highlighted here is the genetic lineage and where SARS-CoV-2 resides in comparison to some of the other coronaviruses. You can see that it's most closely related to the SARS coronavirus, which is now renamed as the first SARS coronavirus. and clearly distinctly different than the other endemic coronaviruses such as HKU1 and OC43 and some of the other ones like 229E that some of you are aware of and see on a regular basis. It's also genetically distinct from MERS. Moving on to the next slide. This is to understand this further and potential vaccine that could be developed. You can see here on the left is the CDC diagram of SARS coronavirus. Those balls, quote-unquote balls, or spikes sticking off of the surface of the circle of, or ball of coronavirus are the spike protein. From that standpoint, the genetic sequence is listed here above, and S stands for spike protein. Within that spike protein, there are several things worthwhile highlighting. There's the S1 component and the S2 component. There's relative more homology among the S2 component, whereas the S1 component is fairly different from coronavirus to coronavirus, and particularly through the receptor binding domain, which is the RBD area that's listed there. And what you can see is that even in comparison to its closest neighbor identified from a bat sequence, there's fairly little homology in that specific region. And another thing to highlight here is that you can see that even in this initial family sequence of isolates that were identified, there was some genetic changes that were happening even at the very beginning in SARS-CoV-2. Fortunately, there's been a fair bit of wobble, but there hasn't been a huge amount of drift in terms of the viral genetic sequence, although there have clearly been some changes that could impact things. Moving on to the next slide. So there are other proteins that could be relevant, but most of the work is really focused on the spike protein rather than on some of the other proteins that are listed here. Moving on to the next slide. And what you can see here is in pre-published manuscript, here is a comparison between the spike protein receptor binding domain and its percent homology among the other coronaviruses. And so you can see for SARS-CoV-2 has about 73% homology with the original SARS coronavirus receptor binding domain, but then even in comparison to MERS, it's down at 16%, and then the other endemic coronavirus is about 10% homology. So as such, it appears very different to our immune system than all the other coronaviruses through this key portion of the virus, the spike protein domain. Moving on to the next slide. So I'll highlight some of the important things along the way. First, we should not have been surprised about pandemic. I think all of us were a little surprised it was a coronavirus, but we shouldn't have been that surprised. A lot of us do worry about the possibility of an influenza pandemic in particular, and that still remains in the background. It does bind to the ACE2 receptor. It is most closely related to the original SARS virus. The S2 is fairly similar, but the S1 has less homology, particularly through that receptor binding domain. There are other proteins that could serve as a focus for a vaccine, but really the spike protein is the focus for the vast majority of the vaccines that are moving forward. Going on to the next slide, you can see here in a nice paper that was published by Florian Kramer out of Mount Sinai. This highlights several things. So one is here's a cartoon of the receptor binding domain in purple. And within that spike protein, you can see then he has listed the different vaccines in broad categories: live attenuated, inactivated, vectored, recombinant protein, DNA and RNA vaccines. You can see that really there are at present no live attenuated vaccines that are moving forward for SARS coronavirus. That's always a possibility, but as far as I'm aware, nothing's moved into clinical trials or even into animals yet. There are a number of live attenuated vaccines that you are familiar with, but this does not appear to be a formulation that's going to move forward anytime soon. There are also inactivated vaccines. So in essence, you take the virus and you inactivate it. So flu used to be primarily made that way. Also, IPV and hepatitis A are made that way. This is a strategy that has moved forward internationally, but I think will not move forward here in the U.S., at least not anytime soon. The vectored vaccines is a formulation for vaccine that's quite different than most people are routinely aware of. The best example that's currently licensed is the VSV backbone Ebola vaccine. So in essence, uses a backbone of VSV and then adds the nuclear protein from Ebola in order to generate an immune response. So this is a strategy that will be used for some of the vaccine candidates that are moving most quickly. Your classic recombinant protein vaccines, I have some listed here. Those are strategies that are taking a little longer to move forward, in part because you have to make the protein, ensure that it's stable, and some other things as well. And so these strategies have moved a little bit more slowly into the clinical trials. Finally, there are RNA and DNA vaccines that I'll talk briefly about on a subsequent slide. Commensurate with clinical trials, you need to be achieving FDA and EMA licensure. You need to develop GMP-grade product. You need to produce and distribute vaccine. And ultimately, a vaccine will have to be administered in order to generate an immune response. Moving on to the next slide. This is taken from one of the manufacturers, and I've hidden which manufacturer, but this just highlights the strategy of an mRNA vaccine or a DNA vaccine, which is quite different than strategies that have been used for other vaccines. And what you can see here is that what is typically done is that an RNA or DNA vaccine is encapsulated within, for RNA vaccines, these are within lipid nanoparticles that are then taken up by the cells. And the cells themselves actually see the mRNA and they don't know that it's exogenous mRNA. They just go ahead and make the protein that the mRNA codes for, and that protein then is either degraded through proteasomes and presented through MHC class 1 presentation to CD8 cells, or it's presented on the cell surface, or actually leaves the cell surface and floats exogenously and then is either taken up by a antigen-presenting cell, or that mRNA vaccine may be taken up directly by antigen-presenting cell, and then through MHC class 2 is presented to CD4 cell to result in T-cell responses. So these are definitely different strategies than have been done previously, and if an mRNA vaccine were successful in any of these trials, it's a strategy that might be more frequently used in future vaccines. Of course, no mRNA vaccines moved completely through to licensure yet. Moving forward to the next slide. Just as a brief reminder, there's different phases of clinical trials. Phase 1, small numbers of individuals. Really key is moving somewhat slowly to ensure safety. And one of the goals is to start to try and narrow down to a safe dose. In your phase 2 trials, it's further to evaluate safety and as well identify the ultimate dose that will move forward in the phase 3 study. Phase 3 is the first time that you can really evaluate efficacy. So does it actually work? And typically these will be in the thousands of individuals that will be enrolled in these studies, typically placebo-controlled trials. Overall, historically, only about 5% of vaccines will make it all the way through to licensure. So far, we do have several vaccines that are arriving at phase 3 studies, which is good news, but still only about 25 to 30% of vaccines actually make it through the phase 3 to licensure historically. Post-licensure, there will be evaluation of effectiveness and for other rare side effects. Moving on to the next slide. Here are some of the candidates that are moving forward. In red, I have the inactivated vaccines. I think all of these will probably not move forward in the U.S., certainly not anytime soon. These are taking whole virus and inactivating them. The protein subunit vaccine manufactured by Novavax is moving into clinical trials. That strategy has been a little slower than the non-replicating viral vectors at the top, which are the Oxford construct, the chimp ad, and then there's also adenovirus type 5 that's been used in Beijing, in China. The RNA vaccines, and there's two that are currently in clinical trials. One is the Moderna vaccine and the other is with Pfizer. Both have some preliminary data available. We'll talk about that in a little bit. Moving on to the next slide. So the background preclinical work is critical to advancing vaccines. Fortunately, a bit of background preclinical work had actually been done with SARS coronavirus and then also with MERS that allowed for things to move more quickly. There are three stages of vaccine development. A fourth happens after licensure. There's been, in essence, an effort to move forward very, very quickly, and that's resulted to some extent with kind of out with the old, in with the new. But ultimately, we'll have to wait and see what actually makes it all the way through to licensure. So I'm not sure that we'll be totally abandoning the old strategies for vaccine development, but certainly some of the newer platforms are faster. Most vaccines that actually start in phase 1 don't actually make it through to phase 3, and many, even in phase 3, don't make it through to licensure. It's been a big S protein focus, and then there's over 100 vaccines in preclinical development with about 10 in current clinical trials. Moving on to the next slide. That is good news in hopes of us ultimately having a vaccine. This just highlights then the immune response, and for those of you that don't think about immunology on a regular basis, a couple key things is that the initial primary response is slower and less robust. With re-exposure, you see a more robust response that happens more quickly. And we'll move on to the next slide, which demonstrates this. In one study that we conducted with the H7N9 influenza vaccine, you can see here, and if you just look at the blue here at subjects received vaccine on day 0 and 21, you can see that there was really minimal response at day 8 and then at day 21 to vaccine. Post the second dose of vaccine, a week later, you see a nice robust response that then remains in the same general range in follow-up at day 42. You can see that there's marked age dependence, and this is actually going to be important for most of the vaccine constructs going forward, is that as we get older, unfortunately, our immune systems do have some immunosenescence that happens. So will the same dose be required for someone over 65 versus someone who's 25? That's an uncertain question at the moment. Moving on to the next slide. So another key thing worthwhile emphasizing is that safety is not necessarily the same as reactogenicity. In general, there's been an effort to minimize reactogenicity, in part because worry about unintended safety consequences such as autoimmune disease. Many people complain about getting quote-unquote the flu from the flu vaccine, which is an innate response of the immune system. That happens shortly after vaccination. But it is notable that many safe vaccines can have substantial reactogenicity. And in some ways, some of our fairly reactogenic vaccines have actually been better. So whole cell pertussis actually was clearly better than the acellular pertussis vaccine as far as prevention of pertussis, although much less well tolerated. As well, the shingles vaccine, the current new shingles vaccine, much more reactogenic by far than the old live attenuated vaccine, but yet also works much better. So it is this balance that has to exist, and there is a component to which the patient's perceived benefit does impact their willingness to receive vaccine and willingness to tolerate these side effects. So moving on to the next slide. It's important to note for SARS-CoV-2 that there's been a lot of concern about the possibility of enhanced disease associated with a vaccine. So there are kind of three possibilities for a vaccine. You can either have a no immune response, which is actually fairly frequent in early phase vaccine clinical trials, where you, for whatever reason, either the dose is wrong or the method of delivery is wrong, you just don't see an immune response. You can have an advantageous response, which is, of course, what we all desire. And the third possibility is a deleterious response. And so that has been seen a number of times in the past. Classic examples were the swine flu vaccine in '76 associated with Guillain-Barré syndrome. Dengue, which was associated, one of the new dengue vaccines is associated with antibody-dependent enhancement of disease. which I have listed here as far as the mechanism through which this acts, and then also old RSV vaccine from the 1960s, which was associated with vaccine-associated enhanced respiratory disease, which was thought to be both an antibody and T-cell mediated phenomenon. Partly this is thought to be partly due to a biasing towards a Th2 response instead of a Th1 response. So that is a possibility, and this was nicely reviewed by Barney Graham here in this paper that was published in Science just a short time ago. It's a good reference for people that would like to read more about this. Moving on to the next slide. So we want to quickly move vaccines forward while ensuring stability. So safety is a primary goal for vaccines because they are given to otherwise healthy people. For the phase 1 studies, those always are going to take longer, in part because once you administer a vaccine, you can't take it back. And so typically what's done is that sentinel subjects are enrolled. There's frequent pauses in enrollment. We slowly increase the numbers of individuals receiving vaccine, and then we also escalate the dose to get a sense about what the range for dosing is. A boost is typically needed for many vaccines, and one of the challenges always with the boost is that you'd like to get the boost in before the exposure happens to try and ensure that the patient has an immune response. And so in an epidemic situation, you'd really like to try and expedite the boost dose. So if we move on to the next slide. This is a study, and there's a number of studies with different pathogens that have documented very similar findings. In essence, you can see here there's 3 different treatment groups. One group that received dose only on day 0, another group that received dose on days 0 and 7, and that's the line that the solid line just above the dotted line, and then a group that received boost dose at day 28. And you can see that clearly those that received boost out at day 28 had a much better immune response than those that received boost at day 7. And in essence, this has been seen multiple times that if you try and compress down the window of time, it doesn't work very well. The immune system actually benefits from a period of rest before exposure. So moving on to the next slide. This then just highlights that antibody responses are better after the boost than after the prime. More vaccine doesn't necessarily result in higher antibody titers, and this has been seen for a number of different vaccines, such as smallpox, anthrax, HPV. And really the goal is to have an immune response prior to exposure. In a pandemic, you're tempted to rush the boost, but this can actually be counterproductive in terms of the overall immune response. So moving on to the next slide. I've then summarized this section. Prime and boost is anticipated to be needed for most of the vaccine candidates because that immune response after a single dose is typically suboptimal. We don't know whether that'll be the case for all the vaccines that are moving forward, but it's anticipated that it may be. Safety is not the same as reactogenicity. Maybe we should aim for a little more reactogenic vaccines while weighing the tolerability of those vaccines, particularly if we're seeing better immune responses. The immune response after a vaccine can be deleterious, can be non, or can be advantageous. Obviously, we want to see an immune response that's protective. Unfortunately, patience is required with the phase 1 studies as we try and generate data such that we feel safe to move forward into larger numbers of individuals. In a pandemic, these are focused on moving forward, or trying to move forward at warp speed with a vaccine strategy, but actually aging the immune system is actually similar to that of wine and cheese. With age, it actually gets better from the standpoint that if you rush that boost, it may actually be counterproductive. Moving on to the next slide. So here's a study that we've been involved with, which is a study of mRNA vaccine. We were asked to provide support for Kaiser Permanente with a plan initially to enroll 45 individuals at 3 different doses of vaccine. We were asked in mid-March to join the study, and very quickly got up and activated, needing to move forward at very, very, very quick speed from that standpoint. We've subsequently been asked to enroll into additional cohorts. There's now a total of 13, and we've enrolled 43 as this study's become a little bit of an octopus, trying to evaluate different doses and different age ranges. Moving on to the next slide. A few things that I just highlight from this. the world right now is very upside down in so many different ways. One of the ways in which it's very upside down is that press releases sometimes precede the publication, or things get put into medRxiv or bioRxiv before they're peer-reviewed. There's positives to those things and also negative things. So for the Moderna study that I'm involved with, there was some initial data released as a press release. What you can see there is the press release itself. It's received actually a lot of criticism about the press release. One of the key things that was actually communicated but kind of passed over by everything is that the second dose was less well tolerated than the first, and especially the highest dose, the 250 microgram dose. In essence, that had been the plan to move that forward into the phase 3 study, but that was abandoned for those under age 55. The responses were similar to or greater than that of convalescent sera, both by EIA and also the limited neutralizing antibody data. I mentioned the change of the vaccine dose, and then the phase 2 is actually been started, and many of these individuals have received a boost dose of vaccine with the phase 3 study planned for starting at the end of July. Moving on to the next slide. So for the Pfizer mRNA vaccine, there's data that have been submitted into medRxiv, and so there's a little more data here. I can tell you that there's data imminently due to move into the public domain for the Moderna vaccine as well. But for the Pfizer vaccine, you can see several things. So one is that they used 3 different dosing regimens initially, but then actually with the second dose, they held off on administering the highest dose of their mRNA vaccine due to tolerability issues as well. And they had a fair bit of fatigue, headache, chills, and so forth with even the first dose of vaccine. And then in general, second dose was a little less well tolerated. And I think that that's going to be true of the mRNA vaccines as a whole. They also looked at receptor binding domain antibodies and also neutralizing antibodies, which you can see here. And out at the day 28, they'd given prime and boost at days 1 and 21. You can see that that their responses out at day 21 and beyond are similar to or above that of convalescent sera. And also importantly, they're seeing neutralizing antibodies, which is very important because those seem to correlate across many different vaccines with actual prevention of disease. So that's encouraging data, and more is coming. Moving on to the next slide. The third study for which there's data currently available is using the Ad5 vectored vaccine in China. Actually, a couple of things about this. One is that there's a fair bit of tolerability issues, and second is that their immune responses were not particularly robust. I don't think this is going to move forward in the U.S., but may be an option internationally. One of the challenges is that many people here in the U.S. have pre-existing adenovirus 5 immune responses from prior infections, so that I'm not optimistic that this will actually move into the U.S. Moving forward to the next slide. There's some unique challenges with conducting a study like this, in part knowing who's infected at baseline. There's no FDA-approved assay for actually assessing antibodies at the start of the study. There's ongoing risk for SARS-CoV-2 infection during the study. Should that happen, it will impact safety, reactogenicity, and immunogenicity of the vaccine. There's risk of participants and staff actually from being in a closed setting for several hours at a time. At the time that our study started, there was no universal mask policy, and we had insufficient masks to even get beyond the first 2 visits, but we instituted a policy that we do that, and fortunately we were able to get resupplied. Very simple issues of even being able to get vaccine were impacted by overall infrastructure changes that were happening. So key questions moving forward will be, what is that burden of disease at the time of the phase 3 study? The more burden that exists at the time of the phase 3, the quicker we're going to get answers about whether these vaccines work or not. The vaccine stability at refrigerator and freezer temperatures can be quite variable, so I think the mRNA vaccines probably won't be a great option for global use due to their stability issues. Will we be able to ramp up, distribute, and deliver vaccine, who's going to pay for it? Who's going to pay for the uninsured and underinsured? Who will we vaccinate, particularly when we have a limited vaccine supply, which is likely to happen in the first month or months after receiving vaccine? And then finally, will patients actually choose to receive a vaccine? That's a key question. Not much is really known about that, and there's a Newsweek article that I have highlighted there where 14% of American adults would categorically refuse a coronavirus vaccine. So that will obviously impact our ability to blunt transmission should that be a frequent thing that adults are refusing to receive vaccine. Moving forward to the next slide. There's been a lot of discussion about need for a pediatric vaccine. I think increasingly it's clear that children really would potentially benefit from a pediatric vaccine. Many of us are arguing that this is actually really important for us to move forward for a number of reasons that I have highlighted there, in part to help provide herd protection, and actually herd protection for the whole community as well will be crucial because if we leave segments of our population unvaccinated, we'll have resurgent disease from those populations. Moving on to the next slide. And you can see that that was actually quite helpful, and these are total cases, but actually it was there's been huge impact with things like pneumococcal vaccine, hepatitis A vaccine, in particular as far as blunting adult disease, even to a greater extent than pediatric disease with implementation of a pediatric vaccine. Same thing for rubella, which is kind of an unusual situation in which young children were vaccinated to protect young women of childbearing age who then delivered infants with congenital rubella syndrome. So actually that strategy was actually quite effective with rubella and worked much better than other countries where vaccine was focused just on those of childbearing age. Moving on to the next slide. So there are multiple unique challenges. There's question of whether at some point a challenge might be needed. That's a possibility. Are we really prepared to roll out a vaccine? I don't know. Who do we vaccinate and prioritize? Those are key questions. And then should children be part of a vaccination strategy? I think that actually will be important. Moving on to the next slide. This is a picture from CNN of one of our participants, and so we are in the midst of a search for a vaccine. We'd all love to get back to something resembling normal. We've got a ways to go, but are actively working towards that end, along with many, many other people. And a vaccine, in many ways, may give us the opportunity to move back towards something resembling normal over the course of time. So at this point, I think that's my last slide. If you can go on to the next one. Yeah. In the meanwhile, this is tongue-in-cheek from The Onion. The CDC urges Americans to just say no if a friend does offer them coronavirus, but I think it's a good warning. And I think I'll leave it with that.
All right, thank you. This is Julie Weber, and we're going to go and move on to the updates from the front lines of Arizona and New Mexico. The following speakers do not have any conflicts of interest to disclose. And I'm very happy and pleased to introduce today our two speakers. First, Dr. Daniel Brooks. He's the medical director of the Poison and Drug Information Center and Outpatient Toxicology Clinic at Banner University Medical Center, Phoenix, Arizona. Our next presenter is Dr. Stephen Seifert, and he's the medical director of the New Mexico Poison Center, professor of the University of New Mexico School of Medicine, and coming to us from Albuquerque, New Mexico. Thank you both for joining us today, and we'll move on with your presentation.
Great. Thank you, folks. And it's my honor to be with you and give you an update of what's going on in Arizona. It wasn't that long ago that we were all sitting and watching in horror what was going on in New York and New Jersey and Connecticut, and now we're starting to experience some of the things here. So I'm only going to take about 2 or 3 minutes to just update where we're at and then turn it over to Steve, and then if we have questions, Ziad will handle those for us. But this is a timeline of of how things started, going back to May. Actually, sorry, these slides are out of order. I apologize. Well, yeah, they're all out of order. Okay. Yeah, I apologize, folks. I think my slides are out of order. So this was just, I'll find the slides. You're going to have to be patient with me. I apologize. But this is an update of showing the hot spots of where it is, and it's sneaking across the southern part of the United States, and it's really kind of hit us hard here in New Mexico and Arizona, and unfortunately on the Navajo and some of the other reservations. This is some info from just 2 days ago with the Arizona Medical Association, where we're right at 90% adult ICU capacity, about 82% inpatient capacity, about 50% of the ventilators are being used, and we've got a return of about 20% positive for testing, and we all know the problem with the testing, who's being tested, and maybe we've got some false negatives and such. Just a couple days ago, the federal government said they were assisting and helping to send about 500 extra staff to Arizona. Some of the bigger healthcare facilities in Arizona have already reached out to their other sites outside of this area to get a staff, particularly nurses, who are just, they're burnt out. I mean, walking around in the ICUs and seeing these nurses take care of these incredibly sick folks who are dying. And, we had a very sick patient on our service Sunday night, and I mean, the dialysis nurse that was there with me had been there working for 20 hours, and then she finally asked to go home. And so it's just, things are getting a little tough. We hope, but it's conceivable that we'd be at triage point within a couple of weeks, meaning people may show up in the emergency department and be too sick for admission and be sent home to, die, which is possible. So I'm looking from okay, so here's where it started, the timeline response. So back in January 26th, we had our first confirmed case in the state. It was a young, healthy kid at ASU here in Phoenix who had actually come back right from Wuhan. Then in the beginning of March, we had our first documented community spread of COVID that involved a nurse. Then about 5 days later, Governor Ducey declared a public health emergency. A couple days later, elective surgeries were halted. And then a week or so later, we had the stay-at-home order, which was initiated until April 30th. On April 4th, it was amended and edited, so the initial order, so that different things happened. And then at the end of April, just before it stopped, it was extended to May 15th. Sorry, now I got to go back here. Then May 1st, we resumed elective surgeries. We initiated a blitz of testing where they were trying to do about 10,000 tests, per weekend and just getting it out. About May 8th, we had the reopening started where we had limited businesses. They were asked to, engage in social distancing, but we can imagine how effective that was. And it was right around May 25th when we started to see significant increases in our numbers. June 29th, there was a reopening that was paused where they closed the bars and gyms and movies, and as people seen on television, I'm sure, all the hundreds of knuckleheads face-to-face on the Salt River and elsewhere, tubing and such. And that same week, we had reevaluation of the opening business is going to be performed every 2 weeks in the state to see which way we're supposed to move. Currently, our schools are slated to be closed at least until August 17th, of course, with the psychosocial burden on families with kids and such. So it's just very, very difficult. Elective surgeries were held about 10 days ago or so, but it's very gray, the wording, wording such as, anyone who's anticipated to leave the PACU within 4 hours and whose underlying process won't get significantly worse within 30 days. It should be, anyone who's expected to leave the PACU in 4 hours or whose underlying disease is going to get significantly worse within 30 days, they can go ahead and do the elective surgery. And we understand, the medical reasons for this as well as, the financial implications for continuing to perform these surgeries. So I was going to show you some of the dashboards here. This is the Arizona Department of Health Services has a great website, really good. I mean, New York had a great website, still does. And we've got pretty good information that we're using, and you can see some of the summaries, and they break it down by county. And like elsewhere, this disease obviously is just following the concentration of humans. And this is Maricopa County and Phoenix in here. Then you can see the hospitalizations by day, the gender issues and age. But again, it's by population. And unfortunately, to put that 90% occupancy for ICU beds in better perspective, the vast majority of those ICU beds that are open are at critical access hospitals, many of which, we do outreach at. And I got to tell you, I've been in a fair number of these smaller hospitals' ICUs. They're not ICUs. So it's going to be very, very interesting to see people being transferred from, major academic medical centers in downtown Phoenix or Tucson or Flagstaff and going out into the middle of the wilderness, there's a lot of it here, to be taken care of at these critical access hospitals. We may have to do that, of course. Obviously, we would do that before initiating triage, but it would be very interesting times. Let's see if I can find my, this shows the adult intensive care bed availability in gray, and red is how much is being used, and you can see we're right. This is as of yesterday. We're right at 90%. Again, the vast majority of these gray numbers up here are in small hospitals, which may have a very hard time staffing and caring for these folks, particularly if they're COVID positive. And here's our deaths, and again, it follows population. Maricopa County and Pinellas County for sure, but it's, if you look up here, but in the northeast part of the state where those are Navajo and Apache counties, and it's mostly the Navajo reservation with the Hopi reservation and the two Apache reservations right along the New Mexico border, just their cases per incidents based on population is just through the roof, and obviously they're suffering greatly for lots of different reasons, and one of which is there's over 30,000 people on the reservation without running water, and you have a lot of multi-generational families, like 3 or 4 generations of family living in the same homes, and these are not air-conditioned 6,000 square foot homes. So asking them to engage in maneuvers that we know help decrease the spread of COVID are impossible, basically. And it's very, very sad what's going on the reservations. Our COVID, we were lucky to get involved with the state response, the 2 poison centers here in Arizona. We contacted them at the very beginning of January and said, hey, it was January 6th. We saw what was going to happen. We said, let us stand up a hotline for you. It was started on the 3 weeks later it was started, and it went statewide in March. And we have an 844 number, and we're happy and proud to be doing this work, but I just got to tell you, we're getting crushed. Both poison center staff are just, they're handling thousands and thousands of calls. This is an integrated voice triage system, so most of the calls are handled by the recording if people are patient enough to listen to the prompts and press the right buttons. But I know personally, when I call my bank, I would just want to speak to a human. So a fair number of these calls get shunted through. We had 14,000 total calls in June alone, and then that resulted in a total of 26,000 calls that turned into cases for our staff, and the average call time is about 7 minutes, and that's 26,000 since the beginning as of 2 days ago. So we're proud and happy to be doing this work, but it's a lot of work. And what we're noticing here is, I'm sure what everyone else who's been through this, New York and New Jersey, it's just the fatigue. Our public's getting tired of it. Healthcare providers are having fatigue and showing up at work, and you can just see it on the faces of these folks. And then we also have alert fatigue. Every 3 minutes that I'm on my computer, I've got to fill out a form that says that I can still smell, and it's just tough. And I think it carries over to the media as well, where people are just getting very fatigued. But we're going to get through it, and we're going to get through this. So this is my email, my office number. Please feel free to contact me anytime, and I'll turn it over to Steve.
Okay, thank you very much. And I'm going to talk about something a little different this afternoon, and that is a related, perhaps related phenomenon that's become a public health crisis in New Mexico. Since May 7th, we've had 8 cases that meet the following case definition. History of ingestion of a hand sanitizer, purportedly alcohol-containing, and a documented methanol level. Our patients have ranged from 21 to 65 years old, 7 men, 1 woman. And this has occurred in multiple cities throughout New Mexico. All the patients had a past medical history of an alcohol use disorder. Most presented late, found unconscious, or already with visual complaints. All had non-detectable ethanols on arrival, and subsequently they had non-detectable IPAs, acetone, and ethylene glycol levels. Those are delayed because they are only run in one central laboratory in Albuquerque. The methanol levels ranged from 21 milligrams per deciliter, but that was 2 days after the last reported ingestion, to greater than 500 milligrams per deciliter, and that was at an unknown time after last exposure. Most presented with an anion gap greater than 30, and so most patients were rapidly blocked with fomepizole. They were also treated with folic acid or leucovorin, and appropriate levels were sent to the central lab for analysis of toxic alcohols. 5 of the 8 received hemodialysis. 1 had to be switched to CRRT because the patient was too hypotensive to tolerate hemodialysis. Of the 8 patients, 4 died, including that last patient who had inability to handle hemodialysis. 2 were discharged with severe, persistent, and likely permanent visual deficits, including near blindness. 1 was discharged with mild to moderate persistent visual effects, and that may or may not be permanent. And 1 of the 8 was discharged with no residual symptoms. The New Mexico Department of Health issued a Health Alert Network statement, health advisory, on June 17th. Now, this was more than a month after the first case, but just keep in mind the first case came in on the 7th of May, the second one not until the 29th of May, and then we had 4 cases in quick succession, June 12th, and then 3 on June 15th. So that was when we knew we had a real outbreak related to ingestion of hand sanitizer products that were methanol containing. The Health Alert Network advisory did not identify the specific cities involved, and initially mentioned bootleg hand sanitizer, and they later changed that to include any hand sanitizer product. That's because we did get a few brand names that were associated with the exposures that were purportedly only alcohol containing, and they did not want to prejudice people that they could drink supposedly ethanol containing hand sanitizers. The FDA issued a public statement. This was unrelated to our outbreak, but a voluntary recall on 9 Mexican hand sanitizers that listed only ethanol on their ingredient list, but were discovered to contain methanol. The first 9 were all manufactured by S Biochem, and then they later added an additional 5 Mexican products. None, as far as we know, are involved in our cases. The CDC has also issued now a Health Alert Network advisory that was just 3 days ago that included the FDA warnings on those products and also referenced the cases occurring in New Mexico and some similar cases occurring in Arizona. They're currently collecting data on this outbreak, and they plan on publishing an MMWR report in the near future. The source of the hand sanitizers is currently unknown. In 3 of our 8 cases, a U.S. manufactured commercial product was identified as a possible source. The Department of Health has obtained possession of the residual product, and they're testing them. One was involved in 2 cases and one in 1 case, and the one that was involved in 1 case apparently has tested positive for methanol. But whether this is a manufacturing issue, that it came from the manufacturer with methanol when it said it only contained ethanol, or whether it was adulterated after the fact, is still unclear. And because the confirmation is not complete, and because we don't know whether this is bootlegged or actually a manufacturing issue, we're going to await New Mexico Department of Health public announcements to say anything more on this. For now, I would consider any hand sanitizer exposure whether to a commercial product that lists only ethanol or isopropanol as its ingredient, or to a bootleg product to potentially contain methanol. And I will stop there.
Thank you, Dr. Seifert, for this great update. Thank you as well, Dr. Brooks. This is Ziad Kazi, and I am going to moderate the Q&A session with Dr. Anderson. Dr. Anderson, we have several questions for you, about 8 or 9 questions. I'll try to get through as many of them as possible because I know we have some questions about the second presentation too. So if you don't mind unmuting, and we can go through them rather rapidly. The first question, I mean, you covered a lot of great information in there. I had a quick question. Did you cover every vaccine trial that's being performed right now, or was this a partial, just out of curiosity?
Yeah, so the WHO presents, has on their website, and it was on one of my slides. It has an up-to-date listing that they update on a very regular basis with the ongoing vaccines that are in human clinical trials. I highlighted some of, really with my presentation, I tried to highlight those that had data that was available in some form or fashion from their early results in humans, but there are obviously a lot of ongoing studies. There's a separate question about the chimp vectored vaccine, that's the Oxford construct. They don't really have data in humans in any public forum that I'm aware of, but that is also moving very quickly into the towards a phase 3 study that they're hoping to start in August.
Very good, thank you. Now, I also wonder about colleagues of mine that I work with in the ED. As a matter of fact, yesterday I was working with 3 colleagues that had recovered from COVID-19 infection. Would they need to be vaccinated, or would they be able to skip the booster maybe? Or what do you think about recovered from COVID?
Yeah, you've got kind of a great question there. So the answer to that is that we do know that people can get reinfected with SARS-CoV-2, so that's an important fact. As part of at least some of the phase 3 studies, people will be vaccinated that had prior SARS-CoV-2 infection and didn't know about it, and they will also be assessed for safety and their immune response. So I think we will learn a little bit more about kind of the safety and also the immune response in those that have been previously infected. Right now, we really don't know what the answer is to that question. It's a very good question, and I think we will unlikely have good data about that even when the vaccines are initially licensed, and there'll need to be some decisions about the approach.
So they may not be excluded then. They may be included in the initial, therapy.
So in some of the phase 3 studies, there's not baseline antibody screening that's happening in the individuals. Typically, patients or people that are volunteering will be excluded if they have known infection, but it's probably maybe 5%, maybe as high as 10% of individuals could end up having had COVID-19 previously and not known it. And so there will be data that will come out, but that won't be known for a while.
Very good, thank you. Now, and are we assuming that the immunity that we get from the vaccination and the booster, do you think that will last more than a year, or is it something that's going to be an annual?
Great question. So we don't know about the duration of natural immunity. We also obviously don't know about the duration of vaccine-induced immunity. There'll be studies looking at the immune response in those that have received vaccine versus natural infection and trying to begin to sort out that question. I think as we learn more during the phase 3 clinical trials, we'll have a better sense about what that threshold is as far as an immune response, as can be measured in the laboratory, that might be able to guide us further in answering that question.
Well, thank you.
It may well need a booster, but we don't know if and when.
Yeah, because one of our viewers was asking whether the possible issues with getting a booster, those risks, were they warranted? Was it needed? Would just a single dose modify the severity of the disease and be sufficient?
Yeah, in those that have had prior full vaccination, that's a great question. Again, like so many things with COVID-19, we're learning as we go, and I could give you an answer today, but that'll probably change in a day or a month or 6 months or a year. So it's all kind of opinion. We need some real data.
Of course, I understand. From previous experience, though, do we have examples in other vaccines where a booster may be not needed just because the initial dose generates an immune response? And also, I will add another question to that. So when we talk about the efficacy of vaccines, is there a specific threshold that we say, this is acceptable in terms of percent efficacy, for example?
Yeah, so as I mentioned before during the talk, the neutralizing antibodies have been kind of the best benchmark against which many different viruses that seems to be a correlate of protection for many viruses for which we've developed vaccines. So the development of neutralizing antibodies by several of the current vaccines for which we have data is very encouraging, but we don't know what that threshold of neutralizing antibodies or total antibodies is, which correlates with protection. It is remember, it's a respiratory virus, and with respiratory viruses, you can have an immune response that will prevent people getting sick from the virus, but may not totally prevent getting infected with the virus. So it's what we call non-sterilizing immunity, in which people can get reinfected, but they don't develop severe disease or more serious disease. And so even that would be a significant accomplishment if we could achieve that, even if we can't achieve sterilizing immunity. For a number of the vaccines, the immune response can be quite long-lived. In general, our respiratory tract is a little harder to achieve kind of lifelong protection.
Fascinating. I saw recently some news articles about already a new mutation in the virus. Is this a big issue for us developing vaccines?
Yeah, so good question. So, so that is a potential issue from the standpoint that if the virus itself is changing, that may result in the immune response to the original sequence or original protein could not result in as good of protection against any mutations that develop. That is something that will be monitored for over the course of time. With protein-based vaccines, those are harder to change kind of on the fly, whereas RNA or DNA vaccines, it's much easier to make a change on the fly. You just substitute out a genetic sequence in order to adjust the immune response. So that might work. You probably would need to repeat some of the earlier phase studies, however, with doing that, but it can be adjusted for more quickly.
Thank you. I guess I'll ask the last question, which is the $1 million question. You said that, for example, your vaccine that you're working on will go into phase 3 in August. Realistically, when do your best estimate, when do you think this will be available for?
Yeah, so it is the $1 million question. So the Moderna vaccine is expected to go into phase 3 at the end of July. That's been announced publicly. I think the Oxford construct, which is the chimp adenovirus, is expected shortly after that, with additional vaccines moving forward in fairly short term after that. From that standpoint, for the phase 3 study, remember it's looking at safety overall, but then as well it's looking at does the vaccine actually prevent infection and prevent disease? And so there are those that receive placebo and those that receive vaccine. And what is compared is the rates of COVID-19 infection in those that receive vaccine versus those that receive placebo. So for the phase 3 clinical studies, everyone that's being planned is in the range of 30,000 individuals being enrolled or more at present. And that is in part to have the ability to rapidly identify kind of those endpoint events where people acquire SARS-CoV-2 and have an actual infection. And so how quickly that is achievable depends on a couple things. One is how quickly the trial enrolls. Two is really the burden of disease that's circulating in the communities where the vaccine is being studied at the time that people have developed an immune response against the virus. So we all hate to see a lot of SARS-CoV-2, but if there is a fair amount of disease circulating, it will make it easier to have the number of kind of endpoint infections that will result in the trial being shorter. Whereas if there's very little circulating disease at the time of the phase 3 studies, then it's going to take longer to get enough endpoints. And so those data will be monitored by typically the DSMB on an ongoing basis. And if there is a big difference between vaccine and placebo, that's when they, would be able to make a decision once that substantial difference is identified. So it is possible by the end of the year that there could be differences observed between vaccine and placebo in the phase 3 studies, which would then result in the things then moving to the next step, which would be FDA review and FDA licensure. If the FDA feels that the vaccine is safe and there's clear efficacy, then they could give authorization for its use. It would also typically be reviewed by the ACIP, which is another critical group, which will help to sort out some of these questions for which we have little data, but they'll give expert recommendations. So it's possible early 2020 that we could see a vaccine being used in people outside of a clinical trial setting. So that would certainly be, I think, all of our hopes, and certainly what everybody's working towards is trying to get a vaccine available as soon as is possible. But we need to have kind of that basic safety data after receiving the vaccine, and then understand, does it actually work or not.
Well, thank you. On behalf of all our audience, we want to thank you and other colleagues of yours around the world working on this important project. You're under a lot of pressure, and we appreciate you taking the time to explain some of these concepts to us. That was very helpful. I would like to turn it over now to Julie, my partner in crime, to go over the many questions we have received as well regarding Arizona and New Mexico. Julie?
Great, thank you. I think our first question here looks like it's for Dr. Brooks, and it says, we hear a lot about approaching ICU bed capacities, but little information on how many are indeed COVID-19 cases. What is the breakdown?
Yeah, that's a good question. I don't have it for the state. I know throughout our healthcare system, it's close to 50%, not exactly 50%, but it's close to 50% COVID or being ruled out for COVID.
Great, thank you. And our next question looks like Dr. Seifert might be able to help us with this. Many people have used the methanol-containing hand sanitizers. What advice do you give to concerned citizens as related to dermal exposures?
It's not recommended to use methanol-containing hand sanitizers for any purpose. There is some absorption across the skin, probably, you know, if used in a standard sort of way, it's a trivial amount. But you also have inhalational exposures that can occur in a small room. These are almost certainly people who are ingesting methanol-containing hand sanitizers as an ethanol substitute. And the FDA has not approved methanol as a diluent for any hand sanitizer. Isopropanol would be okay, but again, not a desirable thing to be drinking. And people with alcohol use disorders are going to look to these products as substitutes.
And maybe you can comment on this as well. It says, should all hand sanitizers that say only that they contain alcohol without indicating what type of should be recalled?
I'm not sure I completely understand the question. I think they should list the ingredients. They should be ethanol for the most part, and anything known to have methanol in a commercial product should be recalled.
Thank you. And our next question, Dr. Brooks, can you help us with this? It says, can you describe a little bit about what services the Poison Center provides specific to COVID? For example, do you have a general scripted information or do you triage based on symptoms?
Yes, we have a scripted, the IVR is scripted, so many of the questions can be answered just by listening to the number. And the best thing you could do is, I think on one of the slides we had the number up, but we can give that to you again. But so it is scripted, and most of it comes from the Arizona Department of Health Services, and Maricopa County and other counties also help. But the calls that come through to our staff are handled based on SharePoint information that we keep for all of the folks that are handling these calls for us, about where to get tested, where complaints are. So all the medical questions we take care of, and a lot of them are the vast majority of them are bread and butter questions. We also get a fair amount of non-medical questions that we, when possible, we turn over to the 2-in-1 emergency services, which is only operated Monday through Friday, 8 A to 8 P. So yeah, most of it's scripted, and the non-scripted answers are from a bank of information that we keep on a SharePoint for all of our staff.
Thank you. And also maybe you can comment about, are there preparations in Arizona for setting up tent field hospitals if needed?
I apologize. What was the question?
If there's preparations in Arizona for setting up tent field hospitals if needed?
Well, they're looking at everything. We've repurposed a hospital that had just recently closed, so I think that would be the next best answer. But if we get to the point where we're triaging, that will also include taking care of patients in the exact term I think is unique or unstandardized places, including on the military bases. There's a mall that is pretty much defunct that we could turn into like a mass casualty care facility. We have this hospital that the Corps of Engineers have retrofitted, and then we would be looking at other things like high schools or auditoriums at colleges and such. So we're looking at a lot of different opportunities. Tents are possible, but then you got to air condition them, and you also have to secure them. So tents would be way down on the list of wanted care facility.
Thank you. If anyone can answer this question, can either speaker talk about the program National Expansion of Community Health Aid Program? which is not coming until the fall, and if it can help.
I don't know what that is. I apologize.
All right, we'll go to the next question. So excuse me. There was a question in regards to the hand sanitizer ingestion. Is it intentional to prevent the COVID-19 or unintentional?
Steve, I'll defer to Steve for his cases. We've had, I believe, 27 total cases in Arizona. Not all of them have matched the case definition because a lot of them happened at very small catchment area hospitals where we could not get methanol levels, or by the time that they came down and sought treatment, they were so acidotic, that their levels were below, the methanol levels were below detection. But I agree with Steve. The vast majority of our cases, based on history, is intentional misuse. And that, I think, is a key part. Obviously, we don't want any of these products out there containing methanol, but I actually would take a more pragmatic approach and say, I don't think this is the time to recall things. I think we need everything out there that we can, but we just need to stick to the fact that we can't be using household products, including hand sanitizers, in an inappropriate manner. And I know how difficult it is, and I'm sure a lot of people on the phone can't imagine how people would drink, this stuff. But like Steve taught us, most of these folks are doing it because of alcohol use disorder, and all the reservations are dry, so they can get their hands on these products and they can consume them, and they're like, cheap versions of vodka when they contain ethyl alcohol. But we've had folks using it for COVID-related issues, including an ICU nurse that I've worked with for many, many years. She's very smart and experienced. She's volunteering to take extra shifts in the COVID unit. Well, she had a mistake with a CPAP lining, and it got up underneath her N95, and she just told me a couple of days ago, I'll admit, I know how ridiculous it is, but she's like, I went to the bathroom, I was rinsing my mouth out with hand sanitizer. So, these things happen. We just got to, the take-home message from my standpoint is don't misuse them. And we've been saying this for the last couple of months, and this is just an unfortunate scenario where people continue to misuse them and are having devastating outcomes.
Very good. Thank you.
So let me just add, the FDA initially made the recall notice for the Mexican products voluntary. I don't know if they've changed that to this point, but I just don't think it's a good idea, especially when you have a sizable portion of the population with alcohol use disorders who are going to ingest these as ethanol substitutes, to allow these to be on the market. Whether this is somebody doing it bootleg, whether it's coming from the factory, it's still unclear. But I think our Department of Health will track down the sources, and I hope they will get them off the market.
Thank you both very much. I really appreciate you answering our questions today and your excellent presentations to inform us about what's going on there out in the front lines. And a special thanks to all those in poison centers. We know how hard our specialists, medical directors, everyone's working, and we really appreciate all the service that's going on. And I'd like you to thank you once again for your presentations today.
And this is Paul Wax again. I'd like to thank our moderators, Julie and Ziad, as well as our three speakers, for an excellent presentation. Again, this is recorded and will be online hopefully on Friday, including this PDF of the slide deck. And you can check it out, or you can look at any of our prior webinars that have all been recorded at acnt.net/COVID-19 web. Next slide, please. And just a reminder about our upcoming webinar. We'll continue our weekly series, and next Wednesday at 3 p.m. Eastern, we're going to have a webinar about the global approaches to lifting COVID-19 mitigation strategies, and also lessons learned from the approach to the mitigation strategies. And then we're going to have a research update on remdesivir. So that should be a very interesting update, a drug that's now seeing increasing use in the treatment of COVID-19. Thank you very much again, and have a good day.